everyone. Yeah, I really want to talk about, since we know that CM is the frontline treatment, we want to make sure that when we're intervening with someone, we're actually doing CM so that we can get the maximum effects from the interventions that we're doing. Next slide. So contingency management is a very specific purely behavioral technique that's designed to deliver positive reinforcement when you see a behavior that you've identified as the target. We're talking a lot about stimulant use today, and I think we have the most research related to using contingency management with stimulant use. So we're going to focus on that, but it has been shown to be effective with other substances and other behaviors as well. What we want to do when we see that behavior is we want to give some tangible item as a reinforcer to begin to help reshape what's reinforcing in that individual's environment, help them see that if I do this, I get this kind of reinforcer, and if I do drugs, I get that kind of reinforcer. Drug use seems so automatic that it's hard for people to make a choice, and this changes the reinforcement platform for the individual so that they begin to make more choice. Next slide. So as I said, CM uses tangible, specific incentives, generally in the form of either gift cards or prizes that are given to the individual immediately upon observing the desired behavior. In most of the stimulant research that was done, that desired behavior was demonstrated through a negative urine drug test. It needs to be a point of care urine drug test, not one sent out to the lab, because we need to be able to be interacting with a person, see the negative result, and deliver the incentive so that those get paired very closely together. Again, the goal is to make something other than substance use rewarding, and we want to repeat that as often as possible. Next slide. While those numbers that Dr. Taylor showed show that methamphetamine use is actually somewhat less across the country, in the Western United States, it's been the primary drug for a really, really long time. And more Californians are admitted into a treatment program for stimulant-related problems than any other substance as far as late as the first quarter of 2025. And while there are some medicines that can be used off-label and may be helpful for some patients, we don't have any specific FDA-approved medicine. So the state of California said, we got to do something about this. And through the 1115 waiver process, they became the first in the nation to offer contingency management through this waiver program. Lots and lots of studies show that it works. So California was just following along. And Ivan's going to talk about that in just a few minutes. Next slide. So the key elements that we want to talk about here is we want to make sure that we're very specific in defining the target behavior, non-use of stimulants as evidenced by a negative urine drug test. It needs to be specific enough that we can measure it purely objectively without any opinion running in, because as soon as you get provider opinion sort of helping with that decision, you begin to add variability and therefore the incentives become less consistent. We want to see that behavior as often as possible. So the protocols generally require people to come in a couple of times a week so that they get the opportunity to demonstrate the behavior and then deliver that incentive as soon as you note that negative test. But we also want to make sure that we have a test that's specific and sensitive enough that we're not delivering the incentive if the person had actually used. So figuring out how you're going to measure that becomes really critical. Next slide. In order to implement contingency management, each site that's implementing or program that's implementing will have to make a large number of decisions that will shape the protocol that you're implementing. First of all, what type of contingency management are you going to do? Are you going to do vouchers or gift cards where you give an incentive directly each time? Or are you going to use a prize-based model that generally involves draws out of a literal or a proverbial fishbowl, some of which are just say, good job and other congratulatory responses, and others lead to prizes. How long is your program going to be? Most of the research was done with protocols that range between 12 and 16 weeks. The California protocol is 24 weeks. So how long is the protocol going to go on? What specific behavior are you looking at, and how are you going to measure it. If you're using your analyses, what specifically is required in order to get an incentive. In the case of our protocol and much of the research, negative for stimulants only, all of the stimulants, but you can show evidence of use of other substances, but if you're negative for stimulants, you still get the incentives. By the way, this is based on the previous research that showed that if you make the requirements too strong, like all abstinence from everything, you don't get enough instances of that behavior in order to deliver the incentive often enough that the incentive has its impact. How frequently you're going to see them? What's the incentive magnitude? Are you going to have level incentives? Are you going to use escalation, reset, and recovery? And are you going to include it with other behavioral treatments? In making all of these decisions, you can come up with a standard protocol to make sure that everyone is getting the most effective form of the treatment. Next slide, please. Now, in our substance use treatment system, urine drug testing has for a very long time been focused on delivering consequences. We give urine drug tests in order to figure out if they've been using and then make treatment-related decisions, generally that have sort of a negative valence to the individual based on the results of those tests. Clients are very nervous very often when we tell them that we're going to use urine drug testing because they feel like they're going to get in trouble. What we want to do with contingency management is really flip that script and make this an all positive intervention. So of course we're going to celebrate and we're going to provide incentives when they deliver a negative test. But if they come in and deliver a positive test, we want to celebrate the fact that they made it in, that we get to have that connection, that they are taking responsibility for their behavior, and then work with them to identify what's needed in order for them to be able to move to the next negative test. Next slide, please. Why do CM? Well, because it works and patients really like it. Go ahead, Mary, and play that.
Would be where I am today when I was still using. I have prospects for careers. I have an excitement for life again. It's a complete turnaround.
I'm actually graduating in 2 weeks. I'm ecstatic to be getting my daughter back this month.
It's like I'm starting to go to school, and it's like, because they helped me through it. I never thought that was really worth it, and to know now, it's like I actually love myself, and so it's awesome.
There's story after story like that of the impact that this has made on patients' lives. Next slide.
I never thought I would be where I.
So why use contingency management? Dr. Taylor said it does represent the standard of care. It can be combined with other psychosocial interventions. Staff like it, their morale goes up, patients like it, and in a study that came out just this week by Laura Coughlin, in the VA they showed that it reduces mortality by 41% over a 1-year period of time. It works and it saves lives, which is what we want to do. So I'll turn it back over to Larry so that we can move on with some specific examples.
Tom, thank you very much. Really appreciate that. Next slide, please. I guess these presentations are so comprehensive, we're not getting any questions. but Tom, key points that I get out of your presentation is, number one, your 4 ingredients to success: clearly defined target behaviors, frequent and objective measure of behavior, provide tangible incentives quickly, and withhold incentives when behavior is not observed while keeping a supportive attitude. That to me is just, that's perfect. Second of all, I love your real life videos. It's great to see real humans talking about the success of how contingency management changes their lives. And that's really lovely. And last of all, Tom, I guess you really reinforce the human connection. It's not just the reward, it's that human connection and that positive treatment. So thank you very much, and certainly really appreciate your time and your words.
When you ask people, Larry, what worked for them in a contingency management program, they very often say it was the interaction with the counselor that was them, and they acknowledge the incentives, but that human interaction becomes the most healing aspect. Thanks for that.
Thank you.